everyone. Thank you so much for having me. My name is Rabih Halabi. Thanks, Colleen, for the introduction. I'm very happy to be here. Honestly, I have a special place on my heart for respiratory therapists. I am the medical director for pulmonary diagnostics at the Nova Healthcare System. It's a 5-hospital system in Northern Virginia. Our hospital, actually, Nova Fairfax Hospital, is one of our biggest ones, is the 3rd busiest ER in the nation, actually. So we have a lot of pulmonary diagnostics that happen across our hospital systems, and also we have 4 clinic locations. We're trying to build even pulmonary diagnostics more as well too. You know, part of the reasons why I got into pulmonary critical care is I fell in love with the ICU. And honestly, I fell in love with critical care and managing patients on ventilators. And a lot of my education came from, came from respiratory therapists. Knowing how to manage ventilators, knowing how, troubleshoot and understand vent modes. And at that time, when I did fellowship, I saw a lot of patients with asthma, unfortunately, and status asthmaticus patients getting intubated. And that's something that has changed over the years, and we don't see this pattern as much anymore. And a lot of it has to do, honestly, with the introduction of biologics, in patients with asthma. And this is like one of the reasons why I'm here today, obviously, to talk about Dupixent and talk about the indication of Dupixent and trying to identify these patients, which I'm sure you see every day in your practice when you're doing diagnostic studies on these patients. So Dupixent is indicated for it has different indications. And the reason why it works so well, because it has really good control on systemic inflammation and also localized inflammation. And not only for patients with asthma, but it has other FDA approvals as well too. But right now with patients with asthma, it's indicated for patients ages 6 years and older, even like in pediatrics, ages 6 years and older, with moderate to severe persistent asthma that have eosinophilic phenotype, or in patients that are considered dependent on steroids for the management of their asthma. So obviously this is a sponsored talk. I don't think this is working, but that's fine. Let's see. So this is a sponsored talk, and I'm speaking on behalf of Sanofi and Regeneron for the talk today. And moving on, so these are 3 different patients that you might recognize in clinic. The first patient is an adult patient that has asthma with elevated eosinophils, which is part of like the CBC that we check all the time in patients with asthma. And the most triggers that she has are allergies. Her asthma is triggered by allergies. The next patient that also would be a Dupixent patient is a patient that is considered dependent on steroids for the management of his asthma. And it's also indicated in the patient population in pediatrics, in patients that have asthma that's uncontrolled but have also elevated eosinophils. So obviously, we have a huge number of patients in the country that have asthma. Over 25 million patients have asthma. But what's staggering about it is that 60% of these patients actually have uncontrolled asthma. And only 22% of these patients, 22 out of 100 patients of uncontrolled asthma are seen by a specialist. So the rest of these patients are managed by urgent care, or they go to a primary care physician and they get on steroids on and off. And overall, their asthma is not well managed. And that's why it's really important to partner with, obviously, asthma specialists like pulmonologists to get their asthma under better control. So again, like when we said that a lot of patients have uncontrolled asthma, and here's broken down by patients ages, like obviously less than 18, younger than 18, and adult patients above the age of 18. And almost 40% of these patients have had at least one exacerbation in the past year. Again, this is a very big number of patients with asthma that are still not well controlled. Obviously, this leads to a lot of healthcare utilization, 9.8 million office visits, 1.8 million ED visits, and it still leads to 169,000 hospitalization. So some of the signs and symptoms of uncontrolled asthma include cough, nighttime awakenings, frequent use of albuterol, all these things that obviously we see patients in clinic, and I'm sure patients that you see when you're doing diagnostic testing on that complain about. And the GINA, or basically the Global Initiative for Asthma assessment, it has like 4 different categories, which are not too hard for us to follow, and it tells us basically, it gives us red flags on who's controlled and who's not well controlled. Again, if patients complain about, oops, I don't know what happened to the slides. Sorry about that, guys. I think it's asking for your password. I know worse. I don't know what happened. Oh, there we go. Sorry about that, guys. So these are basically the signs and symptoms of uncontrolled asthma. If they use their short-acting beta agonist quite a bit, if they have nighttime awakenings, or if it's impacting their activity as well too. So the main thing that we understood about asthma in the past like decade or 15 years ago that introduced the biologics into that field and had a lot of patients with asthma now have their disease controlled is understanding that asthma actually is an inflammatory disease. These patients have inflammation, not just in the lungs, but also like systemically as well too. And it's estimated actually up to 84% of patients with asthma have what we call type 2 inflammation. And a lot of these patients have different triggers. Obviously, we know from clinical practice, some patients get triggered by having infections. Some patients get triggered by pollen exposure or dust exposure. So different triggers can cause different symptoms for these patients. And unfortunately, they go back in the loop and it causes more type 2 inflammation in these patients and they end up causing more exacerbations. So moving on to the first patient that we know that it's eligible for Dupixent is this adult patient who has elevated eosinophils, which is part of the white blood cell count, but also her asthma is not well controlled. She's saying that obviously every spring she uses her rescue inhaler 3 times a week, especially before bed. It's limiting her outdoor activities as well too. And these are the red flags that we see in patients that have uncontrolled asthma that's triggered by allergies. Seasonal symptoms, frequent use of albuterol, if they have nighttime awakenings, and also have an elevated eosinophils. And despite being on triple therapy inhalers or even like high-dose ICS-LABA, this patient is still not well controlled. So this patient is definitely a great candidate to be on Dupixent to manage her symptoms. Now the other patient that's also would be a great candidate, and Dupixent is the only biologic actually out there that's indicated for patients that are dependent on steroids to manage their asthma. Same kind of things. This patient unfortunately cannot get off steroids and he's on 7 milligrams of prednisone daily. And every time you try to wean them down, they flare up more. And obviously it causes weight gain. It causes a lot of other side effects as well too that I'll touch base on. So this patient would definitely benefit from Dupixent and has proven that most, if not of all these patients, can come off steroids completely. And lastly, in patients in pediatric patients, ages 6 years and older, it's also indicated in patients that still have uncontrolled asthma despite the use of high-dose ICS-LABA inhalers, or if they're using frequent albuterol as well too. Again, if these patients have elevated eosinophils, they are still considered excellent candidates for Dupixent. I don't take care of pediatric patients, but I'm hoping that obviously pediatricians out there are doing what's best for these patients before obviously they turn into the adult population, and hopefully their asthma is better controlled by that time and they don't end up having long-term side effects from uncontrolled asthma. So one of the main things that I do, when I see new patients with asthma is I ask them about their steroid use. How many times have you been prescribed steroids? Because a lot of these patients go to the urgent care visits or ER or their primary care physician. So you might see that they might get multiple times of steroid bursts. And studies actually have shown that it takes only about 4 lifetime bursts of steroids to cause short and long-term side effects from using steroids. So it's not only that they use it for a few days and they come off and they're fine afterwards. Actually, the more that they use, and 4 times used in steroid bursts would end up leading these patients to have long-term side effects. So again, part of the short-term side effects, obviously we know that increased risk of fracture with osteoporosis, sleep disturbance, increased weight, increased blood sugar, elevated blood pressure. So there's a lot of really bad side effects from using steroids. And we try to honestly use it as a last-ditch effort to treat these patients that have acute exacerbations. And the red flag right now is that, like, when you talk to your patients and they tell you, like in the past year or so, my asthma is not well controlled. I've had a couple times where I use steroids. These patients need to be assessed to see if they have type 2 inflammation, to see if they would benefit from biologics like Dupixent. And a lot of times, honestly, I get good history taken from my respiratory therapist. Especially when they go in for PFTs, they spend a lot of time with respiratory therapists, and they might share more information about the limitation that the disease causes on their life. And obviously my RTs would come back and tell me, hey, so-and-so was telling me that their asthma is not really that well controlled. I'm not sure what they told you, but they're really struggling, or it's impacting their quality of life as well too. So again, this is obviously talking about how it's important to partner with asthma specialists out there, and pulmonologists obviously a great resource to have these patients assessed, because what we can do is that we can see how many times they've used steroids. We can assess their asthma. We can find out if they truly have asthma or not, because they might have different disease states going on that might be causing their symptoms. And also we can assess if they have type 2 inflammation. So this is the reason why as well too, like by checking these biomarkers and checking if they have type 2 inflammation, we can find out if these patients are eligible for biologics. And I'll tell you, like in the past decade or so, I mean, we used to see asthma patients get admitted all the time in the ICU. And I've had, unfortunately, young patients die on ventilators because of status asthmaticus. And they're the toughest population to ventilate. Right now, I only teach about it. I teach about like what I've seen before on vents, because we rarely see it, because most of these patients, or not all of them, in our area at least, are well controlled with biologics. And it caused obviously a great, it had a great impact on their disease course in general. So that takes us obviously to Dupixent. It's a monoclonal antibody. It's not an immunosuppressant. It's not steroid. It would not impact their immune system at all. And what it does is that, from the studies that we know, is that it has basically what we call like a dual inhibition mechanism. It helps with systemic inflammation throughout the body and also inflammation in the lungs. And it helps with decreasing asthma attacks, decreasing exacerbations. It improves their lung function. And it also prevents a lot of patients from being on steroids for the long run. These are the studies that were done in patients. I'm not going to go through these studies, but all what to say is that like, we've had at least about 3,000 patients that were enrolled in studies, more than 3 years of data, and we've had a lot of clinical experience by using Dupixent since 2018 when it came on the market, and seeing the huge impact that it does. And it's actually, to date, it's the #1 prescribed biologic by pulmonologists for asthma patients. So again, back to the studies, the takeaway from this slide is that the patients that were enrolled in these studies were sick. They'd had at least 2 or more exacerbations in the past year. They were using the inhalers a lot. But the interesting thing is that, and we see this all the time in clinic, a lot of these patients had other diseases that are impacted by type 2 inflammation. A lot of these patients have asthma, but they have nasal polyps. They have atopic dermatitis, or they have eosinophilic esophagitis. So type 2 inflammation can cause different diseases besides asthma. So again, going back to the studies a little bit, this is about 3 years of data that we have. The interesting thing, the only takeaway point that I want you to do is understand is basically all these patients that were on these trials, after they were done with the trials, they got enrolled in this Traverse open label extended trial where everybody was receiving Dupixent. So everybody that was on placebo started receiving treatment, and they followed these patients for 9 to 6 weeks. So we have a long history of safety data on using Dupixent. And that would take us to the results. It decreased exacerbations by about 81%. And on average, it increased lung function by 480 milliliter improvement in FEV1, which is substantial, obviously, in these patients. And you see it by the improvement in quality of life that they have. And a lot of these patients, actually, when we see it in 2 weeks, even after starting Dupixent, they start feeling better. They're like, I'm using my inhaler better, less, and I'm not having all these flare-ups, all these nighttime awakenings. So it works pretty fast in this patient population. It was also studied, actually, to see does it work really well in patients that use steroids on a daily basis that cannot wean down their prednisone dose. So they did this venture trial where patients, every patient that was on it actually was using prednisone on a daily basis. And also, yet again, it had excellent results by reducing asthma attacks. A lot of these patients, I believe about 86% of these patients, were able to reduce and completely eliminate the dose of steroids. They're completely off prednisone by the end of the trial. And it also improved their lung function as well too. So even being on steroids does not improve your FEV1, but being on Dupixent eventually, it did improve the FEV1, kind of like what we saw in the other trials. And the pediatric population as well too. So they did this Voyage trial for 52 weeks, and then they enrolled them in the open label extended trial with Excursion. And yet again, we had similar endpoint with decreased asthma attacks, less steroid use, and improved lung function. And all these were proven in all these patient populations. So long-term safety profile in patients with asthma, we know is pretty safe. The most common side effect that patients complain about is injection site reaction. And a lot of times it goes away actually after the loading dose that they have. And I've never had to stop this treatment because of local site reaction. Otherwise, it's pretty well tolerated with good actual side effect profile. There's also another slide talking about all these like treatment emergent adverse effects. And what they're trying to prove here is that, in the trials where they had everybody receiving Dupixent, they had no comparable arm. So nobody was on placebo. So any side effect that these patients might have, or if they got sick or something, so they reported it. But we know from all these trials that it's pretty safe compared to placebo arm as well too, that we have actually over 800 patients on biologics in our practice. And again, I've never had to stop Dupixent for any adverse effect that was major enough. Important things to ask. A lot of patients ask me these questions. Is it immunosuppressant? No, it's not an immunosuppressant. It's not going to impact your immune system at all. There's no known drug-to-drug interactions. There's no initial lab testing or ongoing lab monitoring. I don't monitor labs when these patients start on Dupixent. It is approved for patients as young as 6 years old. And there's no boxed warning. Actually, all of our patients that receive Dupixent, it's at-home injection. So it's pretty convenient wherever they are in the United States. It gets shipped to them wherever they are, so it's at-home injection. And also, the biggest thing is that it's the only biologic that's indicated for patients that use steroids multiple times or if they're using prednisone on a daily basis. The cool thing about it is that, again, it comes in a pre-filled pen or pre-filled syringe, depending on the patient preference. I'll tell you from our practice, it's at-home injection. And Dupixent My Way offers nurses support for at-home administration as well too, and a lot of education as well. And 98% of commercial insurance patients are covered with this. And Dupixent My Way copay card helps a lot of patients, and eligible patients may get it actually with $0 copay as well. So there's a lot of support to get the patients on it. And this is probably one of my favorite slides because it shows how well this drug works, not just for asthma, but a lot of different disease states that are marked by type 2 inflammation. In patients with atopic dermatitis, in patients with asthma, patients with nasal polyposis indicated, or eosinophilic esophagitis, as early as actually like if they're 1 year or older. And also like one of the rare skin diseases, prurigo nodularis as well too. And the latest indication that came through was the COPD indication. So COPD patients that have elevated eosinophils and they have uncontrolled disease, they are now eligible for Dupixent. And it's the only biologic now that can treat asthma and COPD patients. And that would have a huge impact on patients that have COPD that I'm sure you see all the time. So some warning and precautions. It might cause initially elevated eosinophils because it's blocking eosinophils from going from the blood vessels to tissues. But again, there's no like causation by using Dupixent and the development of these conditions. It's not basically, we don't order it for acute asthma exacerbation, but if a patient's still having an asthma exacerbation, they can continue using Dupixent. And we'll also tell physicians to be careful when they stop the dose of steroids because if patients have been on steroids for a while, their body might be dependent on it and they might have adrenal insufficiency. There's some case reports about some arthritic pain, so some patients that have arthritis and they have worsening symptoms, so we have to consider is it coming from Dupixent or not. Parasitic infections, again, it's really does not impact our immune system. And there's about 6 case reports that we're seeing in the studies. Again, if a patient has a parasitic infection, we treat them first before we start Dupixent. And conjunctivitis and keratitis are more likely seen in patients that use Dupixent for atopic dermatitis, for the skin condition, but not for asthma. And as far as vaccinations, they finished all their vaccines. The only recommendation is not to do live vaccinations while using Dupixent. And as far as adverse reactions, I said I think the most common one is injection site reaction. Pregnant patients were not enrolled in the trials, but again, if they used Dupixent and they became pregnant on the clinical trials, it was actually proven to be safe. There's no case reports of any birth defects or anything like that. And same thing with breastfeeding as well too, that it's proven to be safe, but again, patients have the option to be taken off Dupixent if their asthma is well controlled and then get back on it once they're done breastfeeding. So in summary, basically, it's really important to consider talking to these patients, especially if they don't have a pulmonologist, if their asthma is not well controlled. If you're seeing outpatient referrals for PFTs and you're doing this on patients that don't have a specialist, and these patients are struggling, or you see airway obstruction, obviously FEV1 is low, I would highly recommend that these patients be followed by an asthma specialist, by a pulmonologist, to identify if they have elevated biomarkers, to see if they'll be eligible for Dupixent. That can make a huge impact on their life. And again, it's the #1 prescribed biologic by pulmonologists. and also by allergists as well too. But again, it's proven to be pretty safe. Thank you so much for having me. It's been a pleasure.